Thank you. Senator Monning.
Yeah, I was curious, when you talked about the evaluations and looking at best practices and gathering data, you didn't mention patient outcomes. Later you mentioned that it's unlikely for somebody who's received a diagnosis to be declared well or recovered.
I'm not a physician, but that's just how they...
Right. So given that, does the data that you review that the Commission has access to include specific confidential patient data that can define progress or results of early intervention or results of crisis intervention and what's happened after the crisis intervention?
Yeah, we have determinations that we use. For instance, keeping people out of jail. They may have cycled through jail. Hospitalizations, ability to work, homelessness. So we have these criteria that we use for patient outcomes, and that is in the data. But like I said, it's been a laborious process to get the data aggregated in the best possible way.
Right, and I imagine with each county doing its own data collection, they have different systems of doing that.
Right.
But it does sound like it very much does focus on specific patient data.
Correct.
It's not just general observations or conclusions that counties are advancing to you.
No, they're very specific data.
Great. Thank you.
Based on those 5 criteria I just gave you.
All right, thank you very much. Legislative Analyst, Department of Finance, on either one of these items. I know it was informational. Public comments, please come forward. Good morning, Mr. Seelix.
Good morning. Madam Chair, members, Rusty Seelix, California Council of Community Mental Health Agencies, Mental Health America of California. I wanted to speak particularly to Ms. Walter's comments and the comments on the evaluation and where it stands of the Act. There's 2 very recent reports that really answer a lot of the questions from the audit. One was a report that the Oversight Commission came out with in January that looked at all the prevention and early intervention funds, and that's where a lot of the controversy has been, allegations that money was misspent. And it analyzed all the programs, and it would show that the programs all went to the kinds of things you would hope they would go to, which is identifying at-risk populations and steering those people into care. And in another report that just came out very recently, and is not one done by the Commission, shows that the results of the Act appear to be achieving one of its primary goals, which is increasing access to underserved communities. It showed that the number of people in Medi-Cal that access mental health services stayed the same from 2006 to 2012, but there was an increase in the number of Latinos from 110,000 to 160,000, which is virtually all of the gain in numbers served. Latino penetration rate has gone from 3% to 4%, still less than half of Caucasian and African American, but that was one of the main priorities of the Act, was to increase access to underserved communities. And so while we can't, at this time, we don't have a report that specifically ties specific investments in the Act to that improvement, I think there's few other explanations that are logical to explain it. So it appears as though that the Act is achieving one of its main goals. And as Mr. Monning was reporting on, the core programs of the Act are for intensive services to people with severe mental illnesses, and the primary model of care, we know it's a proven model, the full service partnership model, and it succeeds in getting people out of jails and hospitals. Where it hasn't been as successful is getting people into employment as readily as we'd hope, and there's a lot of work to be done on that, and that's a major primary focus. But one of the things that the prevention and early intervention programs also does is it tries to get to people when they're younger and not as disabled yet, and there's more than a dozen programs known as early psychosis programs, particularly for people with schizophrenia, is where you have the worst employment outcomes. And these programs are also becoming an international model of care, and that the Act made possible the state to really lead the country in funding these, and there's an evaluation going on now to document that, but the expectation is that those programs will show that within 2 years, most of the people are back to full-time success as students and full-time employment, and so we're really achieving a lot of our goals and on our way, and I think the Commission is on the right track in getting the evaluations in place, which are long overdue, and the audit was correct in pointing that out. Thank you.
Thank you very much for those comments.
Kirsten Barlow on behalf of the California Mental Health Directors Association, and particularly in response to the questions about the audit, I wanted to mention that California County Mental Health Directors were supportive of the even announcement that the audit would be conducted, and we're also supportive of the conclusions that were reached and are eager and willing and working all of the time to try to find ways to partner with our state oversight agencies to make sure we do have a robust picture of the changes and improvements that are being made in the lives of the people that we serve, and that at the local level counties have the data and know, but to be able to tell that statewide story we agree is an important priority and are glad to hear it's still a priority for the OAC. Also just to mention, as part of that, counties are committed to providing whatever useful, meaningful data needs to be a part of that effort to be able to demonstrate the impact, particularly of Prop 63 in the lives of Californians. And as part of the audit, as you may know, Los Angeles County in particular was really singled out as a leader in the efforts of data collection and evaluation of the system. And since the time of the audit, findings has actually reached out and assisted the other counties to ensure that their efforts can be improved and that they can learn from much of the success that LA County was able to achieve. Our association, because we don't necessarily have a good statewide story to tell at this point today, are trying to do our best to collect data directly from our members, and we're putting together a brochure to try to describe the effectiveness of the services that we're delivering today, and are trying to get that in the hands of legislators and staff as we speak. So hopefully that will be a useful tool for you in the absence of that statewide story that we're all very eager to at some point see soon. Thank you.
Thank you very much. All right, these are informational items. Thank you very much. I know you have work to do, and it looks like you're on it. Thank you. All right, the next report will be the next item is from the Department of Healthcare Services, and we're going to start with the Community Mental Health Overview. Welcome, Mr. Douglas. Hello again. Good to see you.
Great to see you as well. Madam Chair, members of the committee, Toby Douglas, Director of the Department of Healthcare Services. So very excited to be here presenting on our overall mental health as well as substance use disorder programs. As you all know, the legislature over the last couple of years has transitioned these programs to the Department of Healthcare Services, which has been, we believe, just a great addition to our department and the overall both strengthening of mental health and substance use disorder services, as well as our focus on ways that we can do better integration, coordination across physical and mental health and substance use disorder services. I'm also very fortunate to have a new leader, deputy director over our mental health and substance use disorder services, who comes from the counties. Karen Baylor worked in San Luis Obispo, has a long track record experience in this area, now working within our department, both as a way to work across the department, and you'll hear today how we work not just specifically within the divisions and area of mental health and substance use, but across, working to connect and make sure that we're looking holistically at our consumers. But for most of today, Karen will be doing the presenting, and I'll be here to answer questions. So thank you.
Thank you very much, and welcome to Karen Baylor.
Good afternoon. I'm Karen Baylor, Deputy Director, and I've been with the department, I think, 7 months. So thrilled to be here, and thank you very much. I love to talk about mental health and substance use disorders, so I'll try and keep this brief and not go on and on and on for 5 or 6 more hours. DHCS does administer the 1915B Specialty Mental Health Services Waiver for our Medi-Cal beneficiaries. It is available to all Medi-Cal beneficiaries who meet the medical necessity criteria, and it is administered locally by each county's what is called the mental health plan. And the services generally are outpatient services and inpatient services. And on the outpatient side, we do the assessment, plan development, medication support, state treatment, crisis intervention, crisis stabilization, targeted case management, And in the inpatient, it's acute psychiatric inpatient hospital visits and psychiatric inpatient hospital professional services, a fee-for-service hospital. We are going to talk about some of the expanded benefits here coming up, but we also, I also was going to talk about Mental Health Services Act, which DHCS is actively involved with as well, but you just heard part of that presentation, so I'm going to move it on. Anything else?
Okay. All right. Any Department of Finance or LAO comments on that part of the agenda? Public comment? Members? That's informational, so we can go on to the next item. Oh, I'm sorry. Department of Finance, do you have comments?
On realignment, 2000 realignment, they're going to take the lead.
I'm very sorry. Yes, that's
okay.
correct.
We'll work together.
Department of Finance,
Department of
please
Finance.
proceed on the presentation on realignment. My apologies.
All right, so I will answer question 1 in the agenda. There has not been a formula set yet for the behavioral health growth allocation, but the administration continues to work with counties to find a final allocation formula.
Okay.
So,
Is there a timetable for that?
there's no set timetable at this time.
Okay. I was just making sure we'd covered everything.
Okay.
Thank you for being so efficient. So, do you have any additional comments on the questions that were raised by staff?
Yeah, I would like to talk about some of the monitoring and oversight. On the mental health side, we do have what's called a triennial. We have a department within DHCS that goes out to the counties every 3 years and does a full on-site comprehensive review. They will look at access to services, target population, hard to reach, and homeless persons, and a whole array of services, as well as their quality improvement projects. We will even call their 800 number and be bilingual and want to see how each county handles that access to care. After the complete of the review, there is a report that's done, and then if there are areas where there needs to be corrections, there is a plan of correction that is requested from the county. We also have what's called an external quality review organization, which is required by federal law, and they come out once a year and they look at service capacity, accessibility of services, beneficiary satisfaction, safety and effectiveness of medication practices, continuity and coordination of care, and each site review really does focus on quality, access, and timeliness. They do an annual report, which then each county mental health plan has to respond to.
Okay, thank you very much. Any comments? Members? Public comments, please come forward.
Hey there. Hello again.
Go ahead,
Rusty
Mr.
Seelix, California Council of Community Mental Health Agencies. So on the funding and the growth formulas for allocation, we're at a time of the year when it is actually very urgent that the department come forward and say something publicly, which it has said to us in conference calls 3 times, but never said on the record publicly or in writing. Maybe they could say it today, which is that the EPSDT funding and the drug Medi-Cal funding are entitlements, and that if a county has spent more than its allocation, that will be a first claim on growth. And if a county has spent under its allocation, it will have a debit for growth, and that will be affected in the growth formulas. We understand there's been a challenge in terms of getting the data and having a delay in terms of when to make the adjustments to the counties, But the problem that we've seen in the last 2 years, and this is more on the EPSDT side, which is Children's Medical Mental Health Services, is that many counties tell their providers that funding is capped, and that when you reach your contract maximums, we're not going to send you new children until the start of the new fiscal year. And so what happens to those children? The counties operate some very limited clinics on their own, while more than 80% of the EPSDT services are contracted out. The services operated by county clinics are much more limited. So the children are not going to get, in those instances, the same services they would have gotten if they had entered the system at a different time of the year for that period of time. And we think it's very important the department clarify this policy, which they've told us several times privately, and hopefully get something out in writing, so that this year won't be like the last 2 years, where we've seen this really, horrific problem in many counties. It's not universal. Some counties have taken the word of the state that says, yes, it's an entitlement, and expanded. They haven't gotten the funding yet, so they have a concern from a cash flow, but they believe that, the state will be good to what it has said. But other counties don't believe that and believe it's capped. So we're hoping that Ms. Baylor or Mr. Douglas could make some kind of a statement today that would alleviate those fears, so that we could get the word out that, no, it's an entitlement and it operates that way, and that they will get a credit if they go beyond their allocations. Thank you.
Thank you, Mr. Felix. Would you like to respond to that?
Sure, I'd be happy to respond. So the overarching point, Medicaid, which we call Medi-Cal, is an entitlement, meaning that the individuals meet the eligibility criteria, and once they're on the program, if they meet the medical necessity criteria, they are entitled to the services. This is no different. It doesn't matter who's administering the services. The services must be provided based on that entitlement. We in California have delegated responsibility for mental health to our counties, as well as substance use treatment services. They are still entitlement. We have repeatedly made that point, and most recently we did a county letter back in January 30th of 2013 to our counties, and that went also to all other administrators, and it's on our website, and we can look at redoing it again, but makes it clear again, the entitlement, the requirements. There's no ability to cap services. If someone meets the medical necessity criteria, they must provide the services.
All right, thank you. Mark, comments?
Yes, Madam Chair, members, Donna Brownsey here today for California Opioid Maintenance Providers, COMP, and with deep respect for both Director Douglas and Deputy Director Baylor. We know that they have communicated that these programs, in particular the narcotic treatment programs, are an entitlement. However, the experience during realignment is that they are not necessarily being administered that way at the county level. There have been numerous instances where counties suppress enrollment because they are concerned about the costs of the program and concerned about any growth, even though growth has been provided. So while we do believe the state is communicating, and we know that CSAC as an entity is communicating to the counties, the fact is that a number of programs are not administering the drug Medi-Cal program as if it were an entitlement, and perhaps there could be some kind of compliance mechanism, some kind of policy by the state that would enforce these provisions, because there's only so many times that we can come back to the state or to legislative offices to yank chains of county administrators who we understand are concerned about their budgets, but these are entitlement programs. There's sufficient growth being provided, and there is such a desperate need for not only the drug treatment services, but many of our patients also have mental health issues that are very difficult for them to get services for. So thank you very much.
Thank you very much.
Kirsten Barlow on behalf of the California Mental Health Directors Association. I know this agenda item is 2011 realignment growth allocation, but there are a lot of different things sort of as part of the conversation related to realignment. So I wanted to touch on just a couple of quick things. Because it came up in terms of the provider perspective that This is not an entitlement in terms of how counties are treating it. We wanted to take major exception to that. I think we have worked very closely with the state to ensure that it's very clear to county mental health directors, and has been for many years, that the PSDT and more broadly the specialty mental health program for Medi-Cal is an entitlement for the adults and kids who qualify for medically necessary services. In the instance that a community provider has a cap placed on their contract, that's not the same as capping the program locally. If an individual is turned away from a community provider, that provider ought to be referring that person back to the county, who holds the obligation on behalf of the state to serve entitled beneficiaries. So, that's sort of our perspective on this, and it's come up over the last few years, actually, in budget context. So we would take exception to the assertion that their county is treating this as a capped program where people who are entitled are being turned away from services. In terms of the actual growth allocation issue, it's our understanding that behavioral health is the only program area that was realigned in 2011 where the base and growth allocation schedule has not yet been firmly set and communicated to counties. As you would imagine, county mental health and substance use disorder budgets are now subject to a lot of uncertainty because of that, not only for the current year, but even the next year's budget, since that's built upon what this year's budget would be, and have already had to present budgets to their county boards of supervisors without this critical piece of information being communicated to us. We've met our obligations to provide the administration with our principles and our recommendations. And our first priority in those principles actually is adequacy of funding for the entitlement programs that are within that account. And just another piece of background to ensure, we're very well aware that as part of the structure of 2011 realignment, our obligation for serving children in EPSDT and adults in Medi-Cal specialty mental health, as well as the AOD side, there are specific accounts that we have to use. It's not just 2011 realignment, actually. In mental health, we have to use 1991 realignment dollars and Prop 63 to ensure that people are receiving the services to which they're entitled. And then just real quick, and CSAC will actually be talking a little bit more about this. Not an issue really agendized, but if you'd indulge us just to mention, one of the implications in 2011 realignment specific to EPSDT has been the KDA lawsuit and the adequacy of funds for 2011 realignment to make sure that as part of the state settlement on that case, the county's obligations administratively as well as clinically to serve those students. It's important that we have adequate funds to make sure that we're able to comply with what the state has agreed to do in court with those, the students or the children who are involved in that lawsuit. And so what we would hope to see is an adjustment made in the May revise to make sure that it's clear we know not just what the state's costs will be for KDA implementation, but what the county's costs will be as part of 2011 realignment for that class of students and children that we are serving on behalf of the state. Thank you.
Thank you for your comments.
Kelly Brooks on behalf of the California State Association of Counties. Just wanted to comment very briefly on the 2011 behavioral health sub-account growth issue. We have been working collaboratively with the Department of Healthcare Services and Department of Finance, and are hoping that the growth allocation comes out very soon. Certainly our folks are relying on those funds as they've built out their programs and doing their planning for future budgets, and so the sooner those funds get out the door, the better from our perspective, and we certainly concur with the mental health directors that stability and predictability are very important principles as we try to plan our budgets. I wanted to talk a little bit about the issue that Ms. Barlow just brought up around the KDA lawsuit. So that the state settled that lawsuit to improve mental health and supportive services for children and youth at imminent risk of placement in foster care. As part of the settlement, the state has agreed to 3 new sets of services: intensive care coordination, intensive home-based services, and therapeutic foster care. In fact, the state had to submit a state plan amendment to our Medi-Cal program for therapeutic foster care. So it's clearly a new service because the state is telling the federal government in a plan amendment, we're going to do this new thing and describing what it is and getting approval from the federal government. The administration has not proposed any new funding to go along with these new programs that they've put forward. It's certainly something that we would like to see in the May revise. And we would just remind the committee that when counties negotiated 2011 realignment, we also negotiated a ballot measure that accompanied the statutory framework, Proposition 30. And under that proposition, it requires the state to fund any plan waivers or amendments that increase the overall cost to a program. And it also entitles counties to 50% of the cost increases that result from federal settlements and judicial orders. So we think that this new set of services is applicable under Prop 30, and we'd like to continue discussions with the administration and the legislature about those implications. Thank you.
Thank you very much. Excuse me. Hello.
Good morning. My name is Wesley Sheffield, and I'm from an organization called Young Minds Advocacy Project. We advocate on behalf of low-income children living with mental illness. And my comments are largely the same, or my concerns are largely the same as those expressed by Mr. Seelix, that in effect, the realignment funding allocation is creating some significant barriers for children in their attempts to access medically necessary mental health services under the EPSDT program. And while we certainly appreciate reassurances that the program remains a federal entitlement and that the state intends to enforce that with the counties, we still believe that on the ground, and we're seeing evidence of this, that in effect, many children are facing new barriers to accessing those services. We believe in large that this is due to the fact that the existing allocation formula creates significant disincentives for counties to invest in the EPSDT program. And we think this is in large part due to the fact that it remains unclear what happens if the EPSDT allocations aren't enough to meet the costs involved with delivering and serving all Medi-Cal eligible youth and delivering those services that are medically necessary. We think this is due in large part to a policy void. There's strong evidence that in this policy void, county mental health plans are in fact treating it as a capped program. We've heard from providers who have indicated that they're hitting their contract caps earlier, that they have increasing number of incidences where counties are failing to authorize requests to provide more intensive and often more costly services to youth. At the same time, we also know that some counties are failing to spend their full allocation, or they're diverting EPSDT allocations to other programs. And this is occurring at the same time that we know that the Medi-Cal eligible population is actually increasing. We think that creating a growth allocation methodology is an opportunity to help prevent some of this disinvestment incentive and ensure compliance with the federal EPSDT entitlement. In particular, we encourage the state to adopt a policy that guarantees counties reimbursement for actual expenditures, bases allocation on actual EPSDT expenditures rather than historic expenditures, and finally, to base the entire behavioral health subaccount allocation on EPSDT spending. In part, those three policies taken together will help incentivize counties to expand the EPSDT program and discourage the disinvestment that we've seen on the ground. Thank you very much.
Thank you very much for your testimony.
Madam Chair, members, Carol Schroeder with the California Alliance of Child and Family Services. I'd like to reiterate the comments of previous speakers, particularly regarding EPSDT allocations, and speak to Mr. Douglas's point about the entitlement. I think that when Mr. Seelix asked about the guarantee that the counties spend in excess of the amount that's allocated to them for the EPSDT expenditures, that it wasn't just a question of reiterating the entitlement. I think all the counties are aware of that. The blockages that we have seen relative to access to medically necessary services actually come about as a result of counties being concerned that there just isn't going to be enough money there for them to cover their share of the cost. And I think, as the prior speaker just said, that the best way that we can address that, one, is to guarantee overtly that those costs are going to be covered, that there is that first call on growth for the entitlement services. Secondly, that that we look at the actual amount spent on those things for further growth expenditures. And finally, that we incentivize those, and this is the interesting thing or the difficult thing about this, is there's 58 different counties, 57 mental health plans. It's so difficult to generalize because each county has a different take on this and a different approach to it. Those counties that have been very aggressive in providing those services, finding those kids, providing the services they need, continue under realignment to be aggressive in finding those kids and providing those services. And those that haven't continue under realignment to do the same thing, which is creating this kind of bifurcation, if you will. We think that there's a third piece here that might be really useful, which is to incentivize those lower performing counties by using a kind of performance standard based thing that would allow them to say, we're going to increase our penetration rate, we're going to increase our services to those kids, if we, even though that the allocation that we get is based on our expenditures in the prior year, we would like to expend more in the next year to assure that we have a greater penetration rate, and that we could do that on a performance-based initiative. So we appreciate it. Thank you.
Thank you very much.